world. So these people that I worked with, including this family that you can see pictured here, kind of had their healthcare needs seen to by a government healthcare system through health posts and sub-health posts in their district, together with lots of different kind of sometimes systematic and more frequently one-off efforts or endeavors by visiting non-government organizations and not-for-profits. And so my kind of entree into understanding what healthcare programming and the evaluation of public health programming was characterized by was really understanding the cynicism and the disappointment that these people felt because of the repeated and sort of chronic failures of the system that they lived in. And so as I said, I went to this place originally to study this marriage system and try and understand its impact on fertility, because all those women who never got a chance to marry never had children, or they had very few children, very few of whom ever survived. And that really just drew me into the world of reproduction, reproductive ecology, reproductive health, and all of the myriad factors that we refer to in the world of public health today as the social determinants of health that were affecting their health outcomes. So in this photograph, I'm having a conversation with the villagers who lived a little down the trail from the previous picture, who were really struggling with how to deal with the proper disposal of human waste. And they didn't have any sort of toileting culture or toileting practice. They didn't have toilets or plumbing or even latrines in their village, and people just would go outside and go to the bathroom wherever they needed to. And so this was a problem that was very vexing to health development practitioners and public health practitioners from Nepal and from outside Nepal, who were trying to help these people combat morbidity and mortality related to diarrheal disease. But there was just a real mismatch in understanding both of disease and health-seeking behavior between the villagers themselves and then the public health practitioners or the development practitioners who were coming to the villages. And so these are folks that I've worked with now for over 20 years, well, gosh, nearly 30 years since I was in graduate school. And so that's been a very strong interest of mine all this time as well. My other field site is in East Africa, where I've worked extensively since the late 90s, actually, with East African people who live in rural places and sometimes quite remote places, in understanding similar issues, some of them health-related community development, and then other ones more clinically oriented or healthcare or community health worker-related programs where people from local clinics are going out into the villages and communities and helping people achieve different healthcare outcomes for ends that they care about. So this picture here is a well baby check that was happening in a village not too far from the hospital that I worked in Uganda. And then I worked extensively with clinicians in the clinical setting during that time and since. I'm still working with them today as they are preparing for mounting a response to the pending coronavirus impact on their hospitals and their communities. And have worked a lot in both maternity and NICU units, in addition to the community-based healthcare sort of outreach teams that brought into the community in that setting. And then, so the work that I've done in the program planning and evaluation world has gone back over many decades and really started very informally in this way where, just having conversations, really not knowing that much myself about program planning or evaluation. But being made aware by people who were the supposed beneficiaries of all of this programming and all of this money that was being spent and all of this time that was being invested in programs that ultimately failed, or worked for a little while but then stopped working for a lack of forward thinking and planning and any kind of decent evaluation scheme to help people understand what was working, what wasn't working, and how to fold that into the program planning cycle so that they could avoid those problems in the future. And a lot of those problems and those kind of missteps that I saw being taken or happening were just the result of not having a rigorous and systematic approach to program planning and understanding the role that evaluation plays in program planning from right out of the gate. Evaluation has to be included in any program planning process. And so, I mean, I think that the not only public health, but also in the development industry more generally, we have a much more sophisticated understanding of the importance of these two things and the ways to get it right from the get-go. And that's really what this morning is about. As you would have seen from the agenda, I'll be talking to you about the 10 steps to program planning, which are embraced by the CDC and lots of different kind of umbrella organizations the world over. And then specifically within the CDC 10-step approach to program planning, I'll be teaching you about a very specific model that's used, which is called the Logical Framework Model, or LogFrame. And so I'll walk you through all of the main pieces of LogFrame and its approach, and I'll teach you a little bit about the history of that, the development of that LogFrame model and who uses it. So I wanted to just pause there after introducing myself a little bit and just quickly hear from you all who you are. So what's your name and where are you from? Where do you work? What are your main duties at work, and who do you work with? What kind of a team do you work with? So if we could just quickly. Okay, can you guys hear me? I'm going to share a few minutes of my favorite program planning and evaluation video. This is familiar to be, Melanie will remember my celebrity crush here is Ernesto Ciroli, who is an Italian development specialist. And the thing I want to impress upon you guys when you listen to the first few minutes of his remarks here, I won't show the whole video, but is the perspective that he takes and the respect that he shows his counterparts that he's working with in settings in Africa, and just a little bit about, I want you to reflect on a little bit on what does it mean to take a user-centric or a user-focused approach to program planning and also evaluation. I think oftentimes program planners and evaluators get very stuck in the mindset of people who are funding programs and neglect to think enough or creatively enough or empathetically enough with our supposed beneficiaries of the programming that we're engaging in. And a lot of the failures that I've seen in public health programming the world over are a result of that failure. So let's hear what Ciroli has to say.
Everything I do and everything I do professionally, my life has been shaped by 7 years of work as a young man in Africa. From 1971 to 1977, I look young, but I'm not. I worked in Zambia, Kenya, Ivory Coast, Algeria, Somalia, in projects of technical cooperation with African countries. I worked for an Italian NGO, and every single project that we set up in Africa failed. And I was distraught. I thought, age 21, that we Italians were good people and we were doing good work in Africa. Instead, everything we touched, we killed. Our first project, the one that has inspired my first book, Ripples from the Zambezi, was a project where we Italians decided to teach Zambian people how to grow food. So we arrived there with Italian seeds in southern Zambia, in this absolutely magnificent valley, going down to the Zambezi River, and we taught the local people how to grow Italian tomatoes and zucchini. And of course, the local people had absolutely no interest in doing that, so we paid them to come and work, and sometimes they would show up. And we were amazed that the local people in such fertile valley would not have any agriculture. And but instead of asking them how come they were not growing anything, we simply said, thank God we're here. Just in the nick of time to save the Zambian people from starvation. And of course, everything in Africa grew beautifully. We had these magnificent tomatoes. In Italy, a tomato would grow to this size, in Zambia, to this size. And we could not believe. And we were telling the Zambians, look how easy agriculture is. When the tomatoes were nice and ripe and red, overnight, some 200 hippos came out from the river and they ate everything. And we said to the Zambians, my God, the hippos. And the Zambians said, yes, that's why we have no agriculture here. Why didn't you tell us? You never asked. I thought it was only us Italians blundering around Africa, but then I saw what the Americans were doing, what the English were doing, what the French were doing, and after seeing what they were doing, I became quite proud of our project in Zambia, because you see, at least we fed the hippos. You should see the rubbish. You should see the rubbish that we have bestowed on unsuspecting African people. You want to read the book? Read Dead Aid by Dambisa Moyo, Zambian woman economist. The book was published in 2009. We, Western donor country, have given the African continent $2 trillion American in the last 50 years. I'm not going to tell you the damage that the money has done. Just go and read her book. Read it from an African woman, the damage that we have done.
Okay, I'm going to stop that there. But I'm imagining that each and every one of us can think of a project that we've been involved in that hasn't reached our hopes or hasn't succeeded in the ways that we anticipated. And I'm wondering if some of us here in this group might be able to reflect aloud in the breakout session that we're going to have in a little while here with your group mates about what happens when you inadequately understand the agenda that is brought to a program by different kinds of stakeholders. And I think it's really important that we as program planners understand that one of the fundamental pieces of successful program planning and successful program implementation is the piece which is known as stakeholder identification and stakeholder analysis. And I'd have to say that among all of the failures in public health programming that I've witnessed myself over nearly 3 decades of observing programming in lots of different settings around the world, I'd say that, you know, lack of understanding or lack of time spent trying to knit together or comprehend or meet the agendas and the needs of different stakeholders is probably one of the most important failings. And that's reflected in the steps that I'm going to be teaching you about today, because as you would have seen on your agenda, steps 4 and 5 have everything to do with stakeholder identification and stakeholder analysis. So just to continue on, one of the things that I've learned in talking with folks that come to these kinds of trainings here in Montana is that a lot of people who are in the kinds of roles that our group members are in today's group are roles that are relatively new to them, and many times folks have come straight from the bedside or from very clinical kinds of careers and are doing public health now without having very much formal training in public health. So I always like to start out with reminding folks what the main areas in public health even are, and how is the thinking on public health programming sort of being shaped by a national agenda, which currently our national sort of umbrella or approach to public health is mirrors an international one as well, but I'll come to that in a second. So the main areas in public health are enumerated, or they're bulleted here on the screen for us. From there are 5 core areas.
I'm sorry to interrupt, but can you make your presentation large again? Thank you.
Behavioral health, or behavioral science, or behavioral health education, or health education plain old, biostatistics, environmental health, epidemiology, and health services administration. Those are the 5 main or core areas. And then there are, as many people in this group would know, there are lots of specializations within each of those. So one of the specializations is global health, which I know some people in this group are interested in addition to myself. So my sort of areas within public health are global health and behavioral and social science theories and approaches, and how they help us understand how to structure program planning, and also how do we use our understanding from across the social sciences to compel people to change their behavior, because public health programming and implementation isn't just about the hardware. In other words, the vaccines or the program components or pieces, the tech, et cetera, that we're rolling out, but also in getting people to change their behavior in ways that they may perceive to be as costly, either in time, effort, or even financially. So currently, in the United States, we are following what is referred to as Public Health 3.0 as an overarching agenda. And the schematic on your screen here shows from the late 1800s up until the present some of the changes over time in the way that the public health sort of world or collection of practitioners has changed from what is referred to here as Public Health 1.0 to Public Health 2.0 and the current Public Health 3.0. And it's really Public Health 3.0 that I would say overlaps very significantly with the some of the overarching goals that are embraced by the international community through the Sustainable Development Goals. So you can see quite a bit of overlap there. So Public Health 3.0, it has those 2 bullet points in blue there, and has an emphasis on engaging multiple sectors and community partners to generate collective impact, and also to improve the social determinants of health, which is obviously predicated on an understanding that our health outcomes are affected by much, much more than what is maybe governed in the clinical setting, and outcomes are related to characteristics of our physical, social, economic, ecological environments that we all exist in. And so later on in our in the trainings that we're offering for or through the Public Health Training Center, we are doing one on the social determinants of health as a reflection of that changing sort of emphasis and interest in helping people understand, like, what does that even mean, and how can I use that effectively in my own work. So some specific issues in rural contexts are the same the world over. So we see things like a disproportionate burden of chronic disease relative to the general public. We see also restricted access to healthcare, quality healthcare in particular, insufficient or lack of insurance coverage, geographic isolation, lacking public transportation and poor infrastructure. low educational attainment, low health literacy, poverty and unemployment. As we're all aware, I think, especially folks in the group coming from more rural settings, is a smaller healthcare workforce and lack of specialty care. So some of you in this group are alone on your teams, and that puts a special, sort of weight, I think, on you and colleagues like yourselves. Also, limited availability of bilingual providers, interpreter services, which is a little bit less of a concern for our state, but in some corners and increasingly is a concern. And then cultural or social differences, stigma, and also norms. So those are features that characterize rolling out public health programming in rural or frontier areas, no matter if you're talking about Montana or the Dakotas, or if you're talking about Nepal or Uganda. It's all sort of the same suite of challenges and sometimes even obstacles, but one might also think of them as opportunities. So I think one of the things that I like to emphasize in my teaching in program planning for my colleagues here in Montana is that we're not alone. There are a lot of people all over the world that encounter on a regular basis and solve these very same kinds of problems. So when we're thinking about those solutions to those kinds of problems, we come to the topic of planning, and that's our focus for today. So plans are absolutely key. And it's actually pretty amazing that there are so many projects around the world today that don't seem to have a plan, or have like sort of a fledgling or a half of a plan, or a plan for the early stages of the program, but nothing for the middle or the end. No consideration of exit or sustainability after the funding ceases, and so forth. And so planning is so central to program success. Plans allow you to focus on priorities. They will link your activities to your strategic plan. And I know some people in the group are interested in building their organization's 5-year plan or their 3-year plan. Some people mentioned that when they signed up or registered for our class today. So I know that some of you are kind of toggling back and forth between program planning for a very specific or targeted area like tobacco cessation, for instance, or rolling out a plan maybe focused on improving vaccine coverage or what have you. In some Montana communities, that's an increasing concern or challenge. But also some people are thinking not in like short term, but also in longer term for building their organization's 3 to 5 year strategic plan. Plans also allow you to formalize your efforts, to set expectations and timelines, to keep yourself and your colleagues accountable. They allow you to define roles and responsibilities and to measure impact and validate your programs. You're developing a new concept. Plans can help you chart the way forward to developing proof of concept for your new effort. And they provide continuity through change. Okay. The other emphasis that's kind of a general or foundational one that I wanted to introduce at the outset here is an emphasis on using evidence-based programs and sort of what that means. So, I mean, you know, at its root, the emphasis on using evidence-based programs just refers us back to having data to substantiate both the need for a program's efficacy, and also the need for additional funding, either for an organization to launch a program to meet a particular need, or to sustain a program because existing need is unmet. So using evidence-based programming helps us identify key areas of need and interest based on available data. This includes programs, or could be policies, environmental supports, or health benefit designs. There are all different kinds of ways of thinking about reaching our desired health outcomes or programming outcomes, organizational outcomes that can be evidence-based. Evidence-based programs also support outcomes evaluation, which we're going to be talking a lot about this morning, and can help align our resources or our use of resources and our infrastructure. And with all programs, evidence-based or otherwise, you always want to start out with a good mission statement, 2 to 3 sentences tops. And I'll talk a little bit more about mission statements in a few minutes here. All right, the right questions to begin. These are the 4 most important components of program planning in my estimation. And they're the 4 most important questions that you have to answer in your program plan. The first one is who you are targeting. It has to be specific. When you're too general in defining the group that you're targeting, you introduce measurement problems right from the outset. And the last thing that you want to do is start off with a measurement problem, because also fundamental to program planning is anticipating what evaluation measures do you want to brag about at the end of your program. And if you can't, if you've failed to fast forward or roll the tape forward to that moment where you're talking about the outcomes that demonstrate your proof of concept or how effective your program was, or if you have decided to use a form of a way of measuring that's too general, doesn't really capture the effect of the program, then you've kind of set yourself up for failure right out of the gate. So being very specific helps. The second thing is identifying what you want them to do, the program activities. Again, precision is key. The third thing is how much you want a particular behavior to change. And again, precision here comes into play. You have to be quite clear from the outset that you want to move the dial from, say, for instance, X% to Y%. Or maybe you want to move the number of participants that routinely come to a training or a clinic from 10 people to 20 people. Or you might say that you want to hit at least X number of people. But identifying that from the beginning is absolutely critical, and you will be thankful in the end that you started there. There are lots of different ways to frame that, movement of the dial, as you can see in those 4 points. And then last is when, the when questions. When do you want to see the behavior change happen? Over what time frame, and making that timeline specific and bounded will help you immeasurably. You also have to be reasonable, though. One of the things that I've learned over these years of doing programs, health-related programs, is that it's very quick and easy to introduce the hardware, but the software that I referred to before of behavior change is very slow. And that's particularly the case when people perceive their behavioral change to be costly to themselves. And that cost can be either they don't have the time, so it's a time cost, or it's a financial cost. They don't have the money to, you know, to drive in or gas up their vehicle to drive every single one of their kids in for the their well baby checks or their vaccinations or what have you. So. So that kind of change oftentimes is very slow, and so being reasonable about that is extremely important. Now, I will be digging in considerable detail in a while into what we are referring to when we talk about the indicators that we choose or the metrics that we use to measure program efficacy. And one of the things that I want to impress upon people in the training is that a lot of times people will kind of overthink their metrics or make them overly complex or complicated, difficult to measure, difficult to understand, and that's really not necessary. The most effective messaging about a program's effectiveness is often the simplest form. And so I think that it's important for us, especially when we're starting out in program planning and we're starting out with indicators, or we're starting with a blank piece of paper where you don't know at the beginning exactly what you want to measure or how you want to measure it, using which indicator or which metric, etc. The best place to start is at a very simple place and then build from there. And oftentimes what you'll find is that the simpler measures are perfectly adequate, and you don't ever have to make them any more complex. And so I'll return to that in a few minutes. Okay, so I have a question for people here to answer. So what's wrong with this program objective? Quotes, our objective is to increase participation in the health assessment. Does anybody want to volunteer some thoughts about in what way that's problematic?
The increased participation is not quantified in any way, nor do they have like a time frame in what amount of time they're planning to increase the participation.
Good, thanks, Chuthika. Anybody else?
There's some comments in the chat of too vague, no timeline, doesn't say who or how much or when.
Where is the chat appearing? Here it is. Oh, I'm going to keep this open on my screen over here. Excellent. Yes. No timeline, too vague, who, how much, when, unclear. Also, what is participation? How would you define that? I mean, it sounds good on the face of it, but when you really drill down, what participation means to Melanie might be different to what it means to Marilyn, etc. So that's not actually very useful. Okay, so there are who questions, there are what questions, how much, by when, etc. So much better would be to state it that you, this way, you want residents of X neighborhood. What do you want to do? Increase their participation in the health assessment with obviously some more definition of what participation means to you, from 30 households to 50 households by a particular date. So drilling down into the details like that will always help you in the end. Also, what we see, in addition to an emphasis on using evidence and an emphasis on data, an emphasis on clarity and stating the question and how, or the problem and how reaching your goals will be measured, is action planning. So this is detailed planning for activities that support program objectives. Again, bringing us back to some remarks I shared earlier, this means that we're very clearly going to define at the outset roles and responsibilities, the timeline for each activity, what are the resources needed, both financial and non-financial, and then what are your communication strategies going to be? And those communication strategies might be internal to the organization, between teams or members who are bringing different skill sets to the problem, or external communications. Action planning relating to identification of what are the data sources going to be, where are you going to get the data, are you going to collect the data yourselves, or are there statewide databases that you can draw upon, and what evaluation strategy you're going to use. Okay, so I'm going to switch gears a little bit here from that sort of foundational thinking on using evidence-based programs and clarity and objectives and action planning, and talk a little bit about models. So I'm going to talk about 3 different models, and I'm just checking, do a quick time check here and make sure we're doing okay. We are not doing okay on timing. I'm a little bit behind, so I'll zip right along through here. So I'm going to talk about 3 different kinds of models. And the first 2 are not used very frequently, but well, it's really the first 3, but I wanted to show them to you because I think it's important for you guys to recognize that there's a lot of similarity in or across models that are used for both program planning and evaluation. And so that you know sort of what's out there and where the logical framework approach fits in. The first model I wanted to talk about is used by RAND, and it's called Getting to Outcomes. It's a cyclical model that has, it also has 10 steps like the CDC program planning model. And it has a lot of the same kind of considerations as the 10-step model that you see bulleted in your agenda, the CDC one, but it's just thought of a little bit differently. So you have steps 1 through 6, which are considered to be your planning steps. You have your program delivery steps, and then you have your evaluating and improving steps. And some arrows that kind of indicate what are the connections between those groups of steps are in the middle. And then from, on the outside from 1 to 10 are some of the considerations that, that are used, which will all be very familiar and comfortable to you, hopefully by the end of the training, using slightly different language, which is used by the CDC. This getting to outcomes starts with needs and resource assessment, just like the CDC model, but that I'm going to be teaching you, but then goes on to use slightly different language to get us to the same place. 2 is goals and desired outcomes. 3, emphasis on best practice. Fit, capacity, what's your plan, process evaluation, outcome evaluation, CQI, or continuous quality improvement, and sustainability. And then that circles you back to where you started. So that's the RAND approach. In my social and behavioral sciences class here at UM, I also teach both the pre-seed and proceed models. And those are 2 iterations of the same model. So pre-seed was the first one that came out in the literature and was used for many years. And pre-seed is an acronym that stands for predisposing, reinforcing, enabling constructs in educational diagnosis and evaluation. And so it is a program planning approach that emphasizes social assessment, epidemiological assessment, ecological assessment, and implementation of interventions. So it takes a kind of a, this model is less specific about program planning steps and more holistic in its thinking about what do program planners need to understand about the context in which the program is going to unfold. And the context in this approach, the context, plural, in this approach would be the social, epidemiological, ecological ones, and then the implementation part is understood to occur within those 3 different broader contexts. And then proceed is a little bit different and takes a much more specifically evaluation oriented approach. And so that acronym stands for Policy, Regulatory, and Organizational Constructs in Educational and Environmental Development. And so this program planning approach starts out with implementation, sort of broadly and not very specifically, and then really focuses on evaluation. So process evaluation that's occurring across the life course of the program. Impact evaluation, which is evaluating changes in behavior as the program proceeds. And then last is the outcome evaluation at the end. And those are different kinds of evaluations that would occur or could occur along the way in the CDC approach, but are just really emphasized in this proceed one. So you have getting to outcomes on the one hand, and then you have proceed and precede, and those differ from the approach which is more commonly used across the CDC, across USAID and many, many other organizations that are developing and rolling out health programs across the world. So what I love about introducing LogFrame to settings like this is the knowledge that when you know about, become proficient in logical framework analysis, it's a skill set that you can transport with you into a variety of different settings. So I know like Haley is really interested in the global health world. Virtually every Ministry of Health in the world, whether you're talking about Malawi or Nepal or Kyrgyzstan, they use LogFrame. This is a very popular and very well-regarded framework, and in that way, knowing about it is a real career enhancer in my estimation. So a little bit of history. It was developed in the late 1960s for use in the U.S. Agency for International Development. So in the late 1960s was around the time where people were starting to realize that all of the money that was being used for development assistance, be it health or otherwise across the world, wasn't really netting the outcome that people were hoping for. There are a lot of programs that were sort of flailing along or failing utterly and not really achieving their desired aims, and people were getting a little bit tired of it in terms of legislators and taxpayers here in the United States, and putting increasing scrutiny on the way that our tax dollars were being spent in through the foreign service sector, through USAID and similar bodies. And so you have to understand that the development industry really started after the Second World War. So there's no development industry before that to speak of. But the development industry, including the overriding or overarching financial organizations that kind of dictate international cooperation and development, which would be the World Bank and the IMF, the International Monetary Fund, they evolved out of the Second World War. So initially, development, including health development, was totally focused on rebuilding Europe after the Second World War. So President Truman was the first person ever to use development, health or otherwise, in that context. So that kind of went along, this newly emerging industry kind of went along through the 50s and into the 60s, kind of limping along and sort of not having desired outcomes. In the late 1960s, people really started to put the emphasis on decent program planning and decent evaluation, with the aim of knowing and proving to their constituents, the legislators, knowing the money was being well spent. AID rolled out LogFrame in 30 countries not long after. And now, like I was saying, it's very widely used. So AID uses it, CDC uses it, the UN, tons of ministries, health ministries, etc. So the crucial piece of logical framework is the 4x4 matrix. And I'm going to show you what that is in a little while here. It's a 4x4, 4 cells across, 4 cells down, 16 cells total project table. I love LogFrame. A lot of people criticize LogFrame and they call it lock frame, like lock, like you plan it out at the beginning and then it locks you in place because it's like static, because you like make the plan. Maybe it's like a 5-year plan. Well, 2 years down the road or 3 years down the road, things change. Like so many political, economic, epidemiological, and other things can change, but you're stuck with the plan that you came up with 3 years ago when everything was different. That's wrong. That's a wrong understanding of how LogFrame works, because if LogFrame is used properly, you build into the process periodic check-ins across teams, and you reevaluate, you tweak it, you reorient to your new reality if necessary. So I know there's tons of criticisms of LogFrame by people who made a career out of reinventing the wheel. I love LogFrame. I think it's very useful, and you can tweak it as needed to make it function in any context, even changing context. Another piece of LogFrame is looking at assumptions, and there's a whole section on that coming up. Assumptions are, what are your external positive and negative influences? With substantiation, you got to justify that you think this is an appropriate assumption in your plan. And your plan has to lack a killer assumption. You don't want to have a killer assumption. If that assumption is invalid, it's going to have major negative consequences on your plan. So we're always looking, when we're doing program planning, we always want to make sure that we understand, okay, we're assuming these contingencies are going to be in place, and we have we have sort of a game plan for what's going to happen if something major changes. Okay, so the logical framework approach has these features that I'm going to be walking you through. There's oftentimes, when people talk about program planning and evaluation, those two things often they use the same framework essentially. LogFrame is evaluation, and evaluation is an important part of program planning. So in my mind, they all fit, it fits together completely. And that's one reason that I love teaching program planning and evaluation together instead of separate, because to me, it doesn't make any sense to teach one and not the other. Okay, so in LFA, you have stakeholder involvement. It's a needs-based approach. So log frames or logical framework. Program planning is always based on needs assessment. It's very logical, as the name implies. It's based on a series of if-then statements. It gives us a framework for assessing relevance and feasibility and also sustainability over time. It's very results, not feasults. It's very results oriented. It's not activity driven alone. So other previous ways of measuring the success of a program before people were using the logical framework approach widely was really oriented toward understanding like what program activities got done. So like, for instance, if you said you were gonna improve the people's understanding of diarrheal disease by running 15 trainings over 15 months, then the reporting in earlier days would have just ended there. We ran 15 trainings. That's activity-oriented reporting. That's activity-oriented evaluation. In LogFrame, what you see is a shift from just understanding if the activities got done alone over to results. So we want to see, well, what was the result of that activity taking place? Did people's educational status change on the particular issue that they were being educated on, or do they know the same as they knew at the beginning of the program? In what ways did you affect them through your trainings, etc.? So results oriented. It logically sets objectives and describes their causal relationships, and it shows whether objectives have been achieved using indicators for M&E, or monitoring and evaluation. And last, it describes the external factors that influence a project's success, assumptions and risks. So the main output is the matrix, and it's used to present information about objectives, outputs, and activities in a very systematic and logical way. And like I was saying before, it has the 16 cells in 4 columns and 4 rows. And this is what, excuse me, the LogFrame matrix would look like when it's not filled in. So on the first column on the left, you have a narrative summary of the project starting at the bottom, the project's inputs, which led to its outputs, which relate to its project purpose, which help it achieve its goal. And for each of those rows, in the program planning work that you are going to do, if you use LogFrame going forward, you're going to spend some time thinking about what are your objectively verifiable indicators that you're going to use to know if you reach the goal, if you even reach the purpose. Were there any outputs, and did you use the inputs that you said you were going to? The next column over gets you to think about means of verification. These are basically the ways that you're going to substantiate that the indicators that you used were decent and reliable. And then last are what are the assumptions that you made along the way for each of those rows, for your goal, your purpose, your outputs, and your inputs. Logically, the way that it works is that is illustrated in these if-then sort of relationships that I have on the screen now. So the idea is that if you put in these inputs and these assumptions are correct, then you're going to have these outputs. And then you can kind of work your way up the matrix just like that going along. So if you put in these outputs and these assumptions are met, then your project purpose is going to be met, etc. And I know it sounds a little bit vague now, but I'm going to populate this matrix for us in a few minutes. And I'm going to be using a COVID-19 example through all the examples that I use for each of the 10 steps that I'm going to walk you through today. Okay, so that brings me to step 1, which is defining the problem. The first thing that you have to do, according to CDC in this approach to program planning, and LogFrame as well, is define the problem. There are a minimum of 7 essential requirements to defining a public health challenge in the communities that we serve. And those are as follows. The first thing is you should know something about the population's age and sex structure. So, you know, you have, do you have lots of young people? Do you have lots of old people? Are they mostly male, mostly female? Is the sex ratio at parity, etc.? Something about morbidity and mortality affecting this population. Specific to the problem that you're investigating. Then third, what is the epidemiological and geographical distribution of the problem across the community, across the region, across the state, across the nation, across the world? In other words, you should be able to contextualize the problem that you say that you're going to be working on in some kind of broader context in that way. What are the facilities available to you in, or any other public health practitioner in facing this problem? What's your available person power? How many people do you have available to you to put on the task? What kind of training facilities do you have, and training capacity do you have for powering up that team? And then what are the beliefs and attitudes toward health, disease, cures, and prevention among the population? Absolutely critical to know. Oftentimes we assume that the other people that we're working with share our beliefs and attitudes in ways that is damaging to our program, because that's a big assumption and it can damage your program. A lot of people that I work with in different cultural contexts, they don't share my attitudes and beliefs about disease or health-seeking behavior. They believe that disease is caused by different things than I think it's caused by, and so forth. And you know, it used to be that difference in understanding disease and health-seeking behavior used to be kind of exotified, and people used to imagine, oh, you know, she's only talking about Africa, or she's only talking about places in, you know, other parts of the world that are very, very different to here. But increasingly, we see that's not the case here in our multicultural nation. I mean, we have people from many different walks of life here, even in the state of Montana. We have people with that are migrating here from other cultures with very different beliefs about health and health-seeking behavior. We have indigenous people here who have a set of beliefs about health and health-seeking behavior that may be unknown to people from outside of that community. And these kinds of things have to be understood, at least in some general way, or at a minimum, acknowledged in conversing with people when you're talking about influencing their health outcomes. At a minimum, you want to show people respect, that you understand that they may come to the table with a different way of thinking to yours, and that yours can be complementary to theirs. So, you know, founding the conversation that you have with your clients is founding it on respect and acknowledging these differences is, in my experience, absolutely essential. And I think in Ernesto Cerulli's as well. There are some additional considerations in your program planning procedure that you're going to want to bear in mind. What are kind of your constraints or limitations? They could be technical or economic or social cultural. Are there any other existing solutions out there to the one that you're going to advocate for? Maybe solutions that have been tried previously before you worked in the community that people have rejected or that have failed there and kind of soured the population on? Or are there other solutions that are relevant to the problem that are equally good to your solution but are being used somewhere else? Now, you might not need to know that in conversation with your clients in rural or, you know, urban places in Montana, because the clients themselves don't know there are multiple solutions. But you certainly want to know that if you're talking with other program planners in other counties or other places. Maybe you would come to MPHA in September and talk about your work. You don't want to sound like you don't know that there's more than one solution to the problem that you're trying to address. And then potential setbacks, kind of bringing us back to assumptions. All right, so now we're going to dig down into the COVID, my first example from the COVID-19 perspective. Yes.
Amber, do you mind if we take a quick 5-minute break?
Should we do that now, Em?
That's what I was thinking. If you're about to jump into COVID, we could do a 5 instead of a 10-minute and then get back on.
Certainly. Yes.
Okay, so folks, whoop, go ahead.
Oh, I would say, so we would reconvene at 9:30?
It's 9:28.
Or sorry, 9:35? Yeah.
That sounds
okay.
great.
We'll get back together at 9:35.
Perfect. We can
okay.
reheat coffee.
Okay. All right, I'll see you guys back here, 9:35. Okay, can you hear me, Em?
Yep.
Okay, it's 9:35, so if it's okay with everybody, I'll go ahead and keep going.
Cool.
Just have to fix my screen here on my side. Just one sec. Okay. Oops. There we go. Okay. So in thinking about these additional considerations that I was just mentioning in the previous slide that were bulleted, here's a way that we can think about this with respect to COVID-19 testing, which is the sort of example that I've used as a thread that connects throughout the 10 steps for us to work our way through today. So, so some considerations are listed on the left, and then what would the type of metric be that we could use to understand whether or not we are adequately understanding, meeting those considerations or addressing them. So, so for instance, one consideration would be utility of the intervention and prevention, diagnosis, or treatment. In this case, the type of metric might be comparisons to existing standard of care. With COVID-19, that's a pretty easy one to demonstrate a difference because we have limited testing at present in the state of Montana, and we might like to get to universal testing. Next would be economic feasibility. The type of metric that we would use there would be looking at cost. That would be to do with rolling out a testing program in terms of the cost of the test kits themselves, labor, and so forth. Durability is another consideration, and that has to do with, is the program that you're designing or planning, is it resistant to testable environmental considerations? And those considerations, environmental considerations, might be like not just the physical or ecological environment, but the social environment, political environment, economic environment. In this case, like, are the testing or test results reliable, and do people perceive them to be reliable? So in the social environment there. Sustainability, what's the longer term economic affordability of a testing program? For instance, we might consider in the state of Montana, can local labs manufacture tests? Can they run the PCR analysis, et cetera? What about ease of use considerations? Approval from a sample survey. So will the public tolerate testing via sort of different kinds of testing or test site scenarios, like a drive-up testing situation? Would they come into testing centers, leave their vehicles and go inside, and considerations like that. And then considerations having to do with adherence to quality and safety standards. So can we get approval from regulators? I know that's been an issue here. Does the FDA or other body approve of test kits and analytical labs? I know that Rocky Mountain Biological Lab was approached early on in the evolution of this pandemic here, and was approached by the governor to see if they could do some testing. And they decided that they could not because they didn't have FDA approval. So all of these considerations end up being, obviously very important. That brings us to step 2 in the process, which is conducting a needs assessment. So conducting a needs assessment is going to achieve a variety of things for us. It'll help us identify the issues and where and how resources are best used. It will identify factors that impact health outcomes or health systems. Needs assessments have to be evidence-based and problem-focused. And data from the appropriate population or subsample thereof need to be collected, and they can be collected through a variety of means. You could use surveys, questionnaires, focus groups, meetings, observation interviews. You can pull from existing pools of data that are maintained in databases at the state on demographics, maybe vital stats or hospital records, also lit reviews and that sort of thing. When you're conducting a needs assessment, you need to think carefully about how you're going to sample or subsample the population that your program is intended to benefit. You might randomly sample the population, and there are methods to do that, which would be taught in a whole other course just on study design. But you might also use other sampling methods like purposive samples, where you're purposefully selecting certain individuals to include data from, either attitudinal data or health data or what have you, because there's something about them that makes them appropriate for your needs assessment. You might want to construct a stratified sample because you believe that some way of stratifying the population, maybe by age or by sex, maybe by income or socioeconomic status, has some meaningful impact on health outcomes, particular to the problem that you're interested in. Also, your sample size should be determined by the effect size in the change that you're anticipating. And you also have to think about contact method. So contacting people is simple in some kinds of populations. Like if you want to do research among cell phone users, then it's really easy to contact them because everyone in your sample is a cell phone owner. But if you are, say, wanting to know something about a very rural or frontier population in Montana, that can be tough because not everybody has internet, for instance. You can't contact them in that way. You can't use internet-based surveys. Maybe not everybody even has access to a cell phone or a cellular network, etc. And so thinking about how you're contacting your study subjects is also important in the planning phase of your needs assessment. Okay. Step 3 in the process, after you have completed your needs assessment, is coming up with a mission statement. So mission statements are really important because they draw the attention of your clients, of your colleagues, your other public health practitioner counterparts, also, and maybe even more importantly, potential funders. And mission statements have to be short. You can think of this as your elevator speech or the the amount that you can say in the time that it typically takes to ride an elevator to your destination in a building. So, you know, something short and pithy, and something that will grab your listeners' attention. Mission statements will often help narrow the focus of the project. And you would, for instance, in brainstorming about your mission statement together with your counterparts or your colleagues that you're doing your program planning together with, you might find yourself, through crafting your mission statement, you might find yourself really narrowing the scope of your project. Maybe you would start out, and believe me, I've seen this happen many times, where a group will say, our mission is to eliminate diarrheal disease. And then when they start thinking about what that really means, then they start panicking and they start really limiting their mission statement and chipping away at some of the vagaries and so forth. So they might move from such a grandiose and vague mission statement like that to reduce diarrheal disease in Ward 1 from 80% of household members afflicted with diarrhea at least once monthly to 20%. Very specific and very measurable and easy to understand for your listener. So the mission statement on our hypothetical case that we're working our way through today is expanding COVID-19 testing allows infected people to know they should avoid social contact as well as contact tracing. This allows a more precise and cost-saving strategy than long-term social distancing or stay-at-home orders. So, I mean, it sounds a little stiff because I'm just reading it aloud, but a mission statement should be short like that, a couple sentences, something that you could say in a relatively brief time that will really clearly say what you're going to do and talk about it in a way that other people can understand, and it's not too overladen with technical jargon and stuff like that. Okay, so I'm going to talk about steps 4 and 5 next, and then we are going to pause after this for questions. And also, after the question period, then we're going to move you guys into breakout rooms. And when you're in your breakout rooms, we'll need to talk about who in your group, in your breakout room, is going to be your note taker, your time manager, and also the person who will report back to the broader group. So before we get to the Zoom rooms, in which you're going to be talking about stakeholders and understanding their perspectives, let me walk you through what those things mean and what they are. Okay, step 4 is engaging possible partners who can be thought of also as your stakeholders. So in our case, what we see is that oftentimes the critical stakeholders are going to include community organizations. That can be state, local, tribal, county, etc., governments. It could be educational institutions. It could be people or organizations involved in healthcare, like health education centers or health advocacy groups, even fitness centers. I've seen people reaching out in public health programming to pharmacies and pharmacy staff and so forth. So when you're thinking about possible partners for a public health program, you really just want to think about, in my case, I really just sort of think about myself, and I think about, like, who are the people, or when I'm faced with a health challenge, like, who are the kinds of people that I would reach out to educate myself about the problem that I'm having, to learn about, you know, what are the strategies that I can use to combat my problem, who are the other people around me that have this problem, etc. And I don't know about you guys, but I don't go to my doctor first because it's expensive. I will go to, you know, other people that I can talk to for free, frankly, and that includes a pharmacist. So I think it's really important to kind of think quite creatively about the stakeholders in any given particular or any given public health challenge and program planning challenge, because you want to reach as many people as possible. And sometimes you have to do so through means or channels that are unconventional. So community support is really key to the success of a program that's occurring in the community. And so that's one of the reasons why getting stakeholders on board and recognized and acknowledged and honored and engaged is so important. So we can expect something from our partners in our stakeholder community. It's not just a one-way street, it's a two-way street, really. So they can participate in an advisory capacity, or maybe they can champion specific areas. They can bring their own expertise and insight in to the planning process or program implementation. It also demonstrates transparency to the community that's supposed to be affected by the program, and that is so important. It allows a way of disseminating information and sharing results or materials or data. It gives us a group of people to work with when we're thinking about designing an evaluation that's going to be meaningful to the people who are supposedly benefiting from the work. And they can also actively participate in the planning stage, and in fact, I would argue that they should. They can also share responsibility for getting stuff done, so you can offload some of your work, especially if you have a particular key stakeholder with time on their hands. They also help us ensure cultural relevance, and it's important at the beginning, at the outset, that everybody agrees with and understands roles and expectations. And we can expect our stakeholders to meet with us occasionally. So maybe they might come to planning meetings or community meetings or receptions, events, conferences, etc. They help us share program information with the general public, and as such, their stakeholders and possible partners are absolutely critical. So I think I had 2 slides. I had a repeat slide. Sorry about that, guys. Okay, now, when you're thinking about your stakeholders, you want to think about them in a very clever way. You want to think about, what is the agenda that they bring to the table? What's going to make them happy? What do they need? And so there are some questions that you want to ask yourself when you're thinking about your stakeholders. So for instance, you might want to think about who might be affected positively or negatively by your project. Who in the community has the power to make your project succeed or fail? Who makes decisions about money? Who are your suppliers going to be, and end users? Who has influence over other stakeholders? In other words, who are the opinion leaders in the community? And you know, you might not think that when you're planning a public health program that you need to engage with, say, local ministers or priests, but if you think about it, they could be very important opinion leaders or influencers in a community, and having them, their support and understanding the needs of the community from their perspective and can be extremely helpful in rolling out a program. And that's true no matter if you're talking about the local monastery in the village in Nepal, or if you're talking about getting an opinion leader who is maybe a Catholic priest in Great Falls. Those are people whose opinions matter to locals, and they can be very instrumental in including in our program planning. So you really need to think broadly about your stakeholders and what motivates them and how you can work together to achieve common goals. So also, who could solve potential problems with the project? Who is in charge of assigning or procuring resources or facilities? And who has specialist skills that are crucial to the project? So these are the kinds of things that you would want to ask yourself about each of your potential stakeholders. Now, what are the types of stakeholders that we're talking about here? Okay, so on the one hand, we have users. Those are people who will use the products of the project or program. That would be patients. It could be other co-workers. It depends on what the program is aimed at. You have your governance related stakeholders, and those are people who are on management boards, or maybe they're auditors or regulators or health and safety folks, etc. Then you have your influencers. Those are stakeholders who are, like I said before, like maybe religious leaders or opinion leaders of other kinds in the community, who have the ability to change the direction of a program or a project based on their influence. And you know, I've talked about religious leaders, but you might also think about folks who are you know, active in journalism, you know, through the newspaper, union leaders, and so forth. It really depends upon your community that you're working in. Then you have your providers. And so providers, that means anyone who provides services or resources or other critical needs. Okay, so a stakeholder is any of the individuals or groups or organizations, communities that would have an interest in the outcome of a program or project. And so the analysis that we use in thinking about our stakeholders is to identify what are their needs and interests, and what kind of organizations or groups should we encourage to get involved, what are some potential risks that could put a program at risk of failure, and what are some opportunities in implementing a program. So a very typical way of understanding or doing a stakeholder analysis is to put potential stakeholders on a kind of schematic where you have power on the y-axis and interest on the x-axis. So if we think about COVID-19 testing for you know, 3 different kinds of stakeholders that I have here on this chart, the public might have low power and low interest. We definitely see that. There are some people who are not that interested or motivated by the debate around how to control this coronavirus situation, the COVID-19 pandemic. They're not convinced that it's anything very serious. It's maybe not that different from seasonal flu, and so they're really not that interested. Other members of the public, by contrast, are on the far end of the spectrum and are extremely interested and very alarmed about their own health or the health of their loved ones, or they're not motivated so much by health-related concerns, but they're motivated by economic concerns that are associated with government-level decision-making. So those people would be low power but high interest. Then you have, hypothetically, it could be politically powerful decision makers who have low interest but high power. You could have the counterexample. You could have politically powerful decision makers who are also high power and higher interest. But you could also have agencies like DPHHS that are both high power and high interest in pandemics. And so I think it can be useful as a thought exercise to walk yourself and your program planning counterparts through thinking about stakeholders in this way. Okay, so now I'm going to pause for questions, and I have my chat box open, and wondering if anybody has any questions about anything I've talked through so far. If so, you could raise your hand and Emily will unmute you and you could just speak your question, or you could put it in the chat box. I see that in the chat box, Julie asked if the slides are going to be available, and they will be. So you guys can, you know, write stuff down to keep yourself tracking. I know for me, if I write and listen at the same time, it somehow like imprints on my brain a little bit better. But if you just want to listen and get the slides afterwards, that is, those are going to be available to you. So either way. Okay, Marilyn. Marilyn says, I like to think about all my stakeholders and vector stakeholders and bring them all to the table in phases. Yeah, to ensure the project isn't at risk on day one. They can always let themselves out of the project, but they get bent if they're not included. Isn't that the case? I agree, these stakeholders bring different perspectives to the table. Yeah. Has anybody here ever engaged a particular kind of stakeholder that they think other people in our group might find surprising? Like, like I was mentioning before, you might not think that religious leaders would necessarily be a stakeholder to a health program, but I don't know, are there other kinds of stakeholders that you guys have engaged that are kind of a little bit off the beaten path? Maybe something to discuss in your Zoom room with your group, your Zoom room group shortly. Oh, parents. Oh, that's interesting. Rebecca, you'll have to tell us more about that in your group and when you report back from your group. I'd like to know more about that. Lobbying and advocacy. From Emily, I'm thinking you're meaning like politically active lobbying and advocacy groups in the legislature. That's a good one. I see back here, Emily asked if I'll talk more about killer assumptions and logical frameworks, and I will. I have a section on that a little bit later in the morning, so we'll come back to that in more detail. Well, I'm thinking that now is the time to put you guys into your Zoom rooms, and Emily and Alexis, my colleagues in the training center, will pop into the Zoom rooms and see if everybody is understanding the question, and then, or the questions, plural, and the questions are here. So what we want you to do is get in your Zoom room and just have a chat amongst yourselves, like what in your work, what are your pressing programmatic needs? Like what is the main one that at this point in time you want to put your focus on? And who would your key stakeholders and what would their needs and perspectives be? So should we start with group one? Do the groups know what group number they were?
I don't think so, actually.
Okay. Well, we'll just take a volunteer then from any one of your candidates for reporting back to the whole group. Who wants to go first?
I'll start. This is Raquel.
Kristen does. Oh, Raquel.
Is that all right?
Yes.
Yeah.
Okay, this is Raquel. I think we were in group 4. I was with Melanie, who is out of Great Falls, Cascade County, and Trish, who is out of Webo County. Trish is also an RN, and Melanie works in administrative. So we had, it was really great. All right, so we kind of decided that what program does your community have needs for? The broad general is health literacy. However, we just focused down to right now, there's one need for sure is increase in adolescent immunization rate with all three. The required is pretty good, but the recommended, the HPV and the meningococcal vaccines. And so then we also identified who some of our key stakeholders were, which included schools, Blue Cross Blue Shield, because they offer a great program that will help come out and provide an immunization clinic offsite. Parents, our Board of Health, and healthcare providers, as well as we talked about, like people in the community who will influence. And so we did talk about like church leaders. So those were some of our stakeholders. And then the last one was what needs or perspectives do they have? Which is kind of varying, but we have found that schools have been supportive in these endeavors because they usually have the kids' best interest. And like I said, the Blue Cross Blue Shield, they offer an on-site immunization clinic, so that is beneficial. Parents, of course, as stakeholders and as the users really, it varies because we have some parents that are probably understand the benefit and the need for vaccinations. And then of course there are other parents who have their own narrative and don't maybe understand the need. So it's difficult we have difficulty reaching out and influencing those parents because we also deal with, of course, celebrity influencers, not just local influencers who have, different takes on it than the scientific community, as well as our Board of Health is a stakeholder. Mm-hmm. And and like I talked about, they've kind of been a backseat, but I feel like they could be utilized more as an advocate for programs. And the providers, of course, as advocates. And just the only thing that we found is that We just need to continually educate our providers on the importance of them giving guidance to parents and teens. And then also we did bring up like church leaders, which we do have difficulties sometimes. It really depends sometimes. And we have found during COVID-19 how radical some people are in their beliefs and willingness to ignore scientific data. So we just deal with, again, they would be an influencer of the community, and we just need to find probably those that would help us positively influence the community. So that is kind of what we talked about.
That's great. Really thorough. So remind me again, Raquel, what county you're in?
I'm in Carter County.
You're in Carter, yeah, okay.
Yeah, and so actually it's really great to visit with Trish. I mean, it's good to get other perspectives, but her and I are very similar, as in county size and the type of demographics.
Yes. And when you talk about religious leaders in your community, are you mainly talking about church-based?
Yeah.
Yeah. Uh-huh. And what faiths are represented?
So like in our community as a whole, we have many faiths: Lutheran, Catholic, Mormon, Baptist, and what would be called non-secular, or they're called the Bible Church, so they don't really follow a probably like an offshoot of Lutheran. Or so yeah, we've just had one in particular that we've had some difficulty with COVID-19. They don't understand the restrictions and don't feel like taking away liberties and and anyway, which also I feel translates over into like immunizations. Not understanding.
And Juthika, were you in their group or were you in a different group?
In which group?
I was just asking our PhD student in our program, Juthika, because she's also studying vaccine hesitance with one of our faculty here, Sophia, a newcomer, but Juthika, but I think you were maybe in a different group.
She was in a different group, yep.
Yeah. Yes. I was in group 1.
I see, okay, yeah. But these are all this is familiar territory to you, I would imagine.
Yes. So currently, actually, what I worked on so far is I developed a survey database, kind of that, and then we're planning to send this survey to medical community practitioners and ask them what can be done to improve the vaccination rates and what are their perceptions about vaccine hesitancy and spreading out vaccinations, short limiting, etc. So this is what I've done so far.
That's really interesting. Yeah, maybe other people on the call could consider you and your team as a resource, Juthika, because connecting our public health practitioners from around the state with folks on your team, including Professor Newcomer. I know you spend a lot of time thinking about these challenges. So
yes, sure. Thank you so much.
Share some insights. So I don't know that we've shared emails for everybody around, but I think that we could probably make that available or facilitate contact sharing if people wanted that. So maybe we could go next to the group. Who was the group spokesperson for your group, Lee? Or maybe was Marilyn ready to go next? I feel like you might have started to talk at the beginning there, Marilyn.
I can go if you want me to.
Yeah, let Lee.
Doesn't matter.
Okay, go for it.
Yeah, let Lee go.
Okay. Okay, so in my group was Rebecca Meekum, who is and correct me if I'm wrong, Rebecca, but you run the Eat Smart Montana program. You've also been working with Let's Move Missoula and also working on COVID-19. So you've been super busy. And then Reagan Morley, who lives in Frenchtown and is
actually
working,
we've got wrong names. I'm Rebecca Morley.
Oh, sorry. Okay, yep.
And I run the program for Missoula City County Health Department, not the whole state.
Okay. and then Reagan Meekum, who is living in Frenchtown and is working under a SAMHSA grant that addresses underage substance abuse. She does planning and outreach. So we chose to look at her program, and so I'll talk a little bit about what we reviewed, and then if Reagan, if you have want to jump in, go for it. So Frenchtown in 2008 recognized that they had a high percentage of students that were binge drinking. So they, and we didn't talk about how you initially pulled the group of people together to get the SAMHSA grant, but as part of the grant, they recognized 12 stakeholders and from different sectors. And so this included the schools, parents, students, religious leaders, the Missoula City County Health Department, law enforcement, and their target population is age 7 to 12, or grade 7 to 12. And it sounds like since 2008, alcohol use has been declining, but now they're focusing on maybe marijuana, and then also vaping is becoming a bigger issue. One of the things that we talked about initially is just how everything has changed right now with COVID, and all of the face-to-face programming has basically just come to a screeching halt. And so the way they're running the programs and being able to engage with stakeholders has completely changed. So, and I think it's an interesting thought, because as we move forward, this might be the new norm, is how we're meeting, like for example, today. So we talked a little bit about other organizations that are not part of the 12 sectors, and Reagan couldn't remember all 12 of the sector representatives. But we also, Rebecca brought up CATCH, which is, what's the mnemonic stand for again, Rebecca?
It's Coordinated Approach to Child Health. It's a national evidence-based program for physical activity and nutrition, but they have a wonderful vaping program and a tobacco-free program.
Yeah, so we were talking a bit about stakeholders that maybe haven't been brought in that could potentially be beneficial moving forward. The other, Reagan also mentioned that right now, all of the stakeholders are on the same page, everybody's getting along, and they feel like everything's moving in the right direction, but maybe in the past it wasn't so much that way, but we didn't get a chance to really delve into what those challenges were.
What were they, Reagan? Do you want to talk about that?
The challenges?
Yeah.
So this was before I was involved. I was probably in high school when these were happening. I think people came in with their own agendas rather than sticking to their action plan and seeing our data and what the need was. And so people just wanted to do their own thing rather than working as a collaborative organization to, you know, implement something that could promote substance abuse prevention within the schools.
Got it. Thanks, guys. Should we do Marilyn's group next then?
Kristen is our speaker.
Well, she said you, so yeah.
No, Kristen. You goofer, it's on you, girly. Yeah, Kristen
anyway,
has it down.
Oh yeah. So basically, we kind of talked a little bit, nowhere in the detail that everybody else has. It's like, oops, but we we talked a little bit. I work for the Confederate Salish and Kootenai tribes, and so we talked a lot about, like, if you wanted to create a change, you have to understand what their needs are, not what you think their needs are. And so in order to do that, we have to do a community health assessment. So we're in the process right now of starting to do the CHA and identifying those needs. There are some needs that we are aware of. We have, you know, in the population, we have a high diabetic, high blood pressure. We have a lot of, because of the diabetes, we have a lot of kidney disease. And so one of the things that we were looking at is trying to increase our influenza vaccination for that population. And so for our group, our primary stakeholders are, number one, the tribal council is very powerful, and you can't really do anything within the tribal organization without their approval. And then you also have the individuals within each community, and each community across the reservation has a unique makeup. So what will work in one community will not work in another community. So what we're trying to do is do that, the CHA to identify the different needs in each community, and then from there go based on the needs. But a lot of the barriers that we do have is depending on how people perceive that need. And, you know, it's just like watching our, you know, politics and organizations, and, you know, you get like 3 different perspectives of the same issue, and they don't always agree. And which led us to talking about barriers. And Jennifer was talking about, you know, they're trying to do smoking cessation, and they thought that their call line would increase because people are at home thinking, wow, I got to do something about smoking because that increases my risk of dying for if I get COVID. But it was actually the opposite. And so we thought, well, what's happening is probably there's so much stress out there that smoking is a coping mechanism to keep them sane. And when we think about it, we all know we're supposed to do things healthy, like we should be working out instead of eating chocolate while we're working from home, but we don't because it's our coping mechanism. So we have to get through all of those issues before we can make a plan. So we weren't as detailed as everybody else, and we probably, I don't know if we answered the things that we were supposed to, but that was just basically how we got.
I think that's good, and I love that you brought up the tribal council, because I think that's a great example in our state of an opinion leader that, or an influencer that you have to work effectively and productively and respectfully with, and if you don't, then you know, you're going to be dead in the water. Yeah. And also, I'm really glad that you highlighted the fact that, you know, within tribal communities, it's not like this, you know, monolith that everybody thinks the same. You know, the community differences that you mentioned, even within reservation communities, you know, from one town to the next or one population center to the next can be substantial. And so kind of taking a more nuanced approach and a more realistic approach, I think, is so important. And I found that so much in my work internationally as well, where I'm not even just talking about outsiders to the country or foreigners like myself working in Nepal, but also urban Nepali people who are highly educated or maybe actually elite, who are deployed to rural places, have a similar challenge in perceiving people as in the communities that they have been deployed to serve, perceiving individuality within those communities, and recognizing that, you know, everybody has different agendas, and that there are different kinds of power players than they might be used to in you know, say Kathmandu or urban centers of those places, etc. So I think that's so important. Yeah, I'm glad you brought that up. And what about the last group? Who is their spokesperson?
That's me. And don't worry, Kristen, because I think we were like a little off topic and the time went really fast too. So, but I was with Julie Stearns, who's with the University of Montana, Emily Samhammer with the Montana Primary Care Association, and Juthika, who's a doctoral student. So we kind of got into some overviews of what projects people were on and the stakeholders they've identified and some of the challenges there. Julie talked about her work with students at the University of Montana and how they've seen that mission change over time from something that was primarily kind of tobacco use prevention and alcohol use prevention into a focus on mental and emotional well-being. And that's kind of brought forward new stakeholders. Previously, like the faculty wasn't that involved, but now the faculty has identified needs and are asking for resources. So to address those needs, they formed some campus wellness coalitions, but different stakeholders have different motivations. For example, the administration is really concerned about retention, and that's one reason the shift from kind of the behavioral and substance abuse issues into the mental and emotional well-being, because of it's hard to retain students who are too stressed out and overwhelmed. And then Emily talked about her work with the Montana Primary Care Association and its focus on integrated behavioral health, which does actually kind of overlap with what Julie's work at the University of Montana, in that they're trying to help primary care providers have behavioral health services integrated into their care systems. And that's throughout the state, and it's her stakeholders are really broad and involve like a lot of government entities, as from local on up to the DPHHS and the substance abuse and addiction services. And so those come with their own challenges organizationally and everything. And Juthica shared kind of her stakeholder story and kind of a failure to engage the appropriate stakeholders. And I would say a example of a killer assumption when she was working as an intern at a medical center, and CMS tried to start and roll out an incentive-based reimbursement program, but failed to engage the surgeons that were supposed to be incentivized by this program ahead of time. So it had to do with reporting BMIs, and like they were supposed to counsel their pediatric clients who had high BMIs, but the surgeons didn't feel that was actually appropriate. So they just did the minimum and didn't really engage in the program. So yeah, that's pretty much our summary of just the general issues that people were dealing with their various programs and stakeholders.
That's really good. It's so interesting also to hear from Julie about how in your work on, in such a relatively small and fairly homogeneous community, at least in terms of the project that we're engaged in here on campus, like how vastly your stakeholder analysis would have shifted as a result of changing emphases on, from the university administrations. That's really fascinating. Well, great, you guys. That was very interesting, and I'm thinking we should move on and talk about step 6. And I'm not sure that you can still see my screen or not. My screen can you guys see my screen where it says SWOT analysis?
No.
No, it's not the one that you're sharing.
There we go.
Yep. You're good.
Okay, good. Okay, so the next step in our program planning process, after we think through these considerations having to do with these stakeholder analyses and that kind of thing, is to do strengths, weaknesses, opportunities, and threats way about the path ahead. So strengths, obviously, I think everybody knows what that signals, but here we're talking about the positive internal attributes of program teams. or potential stakeholder involvement. Weaknesses would be negative internal attributes. Opportunities might be external factors that can improve program teams, the program team's prospects, and then threats would be external factors that can undermine your project moving forward. So the purpose of the SWOT analysis is to look both within the organization at its performance and capacity of the participants. Maybe the participants are units, or maybe they're single individuals, and also divisions of organizations more broadly. Each participating unit or team member should undertake a SWOT analysis for their group or their project component. And really it's an analysis that functions as it's an analytical framework that functions as a tool for appraising and brainstorming together with the other people that you're working on the program plan together with. And all the representatives of the organization that's participating in the plan, and ideally including the stakeholders, should fully participate. And so a COVID-10, sorry, that's a typo in my slide here, a COVID-19 SWOT analysis for rolling out a testing program would look at strengths being those residing in existing real and potential stakeholders. So that might be entities like DPHHS, local county, tribal health, Rocky Mountain Biological Lab, Rocky Mountain Biological, which is a company here in Missoula that developed a test kit, the Montana University system, including all campuses, the public's interest in testing, and public's cooperation in rolling a testing program out, a universal testing program out, and really scaling up existing testing that we have, which, as everybody in this group knows, is still relatively limited. Weaknesses might be relating to coordination between all of those potential stakeholders or bodies, and also messaging. So each of those bodies might be independently messaging, and those messages may conflict with one another. So that can be a potential weakness here. Opportunities abound, though, I would say. So, like, for instance, linking together the strengths that are listed above in ways that they haven't worked together previously. You know, it seems like there are untapped resources that the coronavirus or COVID-19 pandemic have uncovered for us in the community, like, say, Rocky Mountain Biological Company, separate to RMBL, the lab down in Hamilton. Rocky Mountain Biological is a company here in Montana that was featured, or in Missoula, that was featured in the newspaper recently as having the capacity to develop a test for helping our communities. So that could potentially lead to business growth or other kinds of collaborations that could be productive, and then could help our state and all of these different stakeholders look ahead to prevent future disruptions from other influenza-like pandemic diseases. There are obviously some threats to consider, and those threats are the economic ones, supply chain disruptions, and also misinformation or outright disinformation from different kinds of media or other sources of information that people rely upon in this day and age, from social media, etc. Now, step 7 is the theory of change step. And theory of change is also sometimes referred to as a logic model. And the output is what we refer to as a problem tree analysis. And this is the step that really starts to help us knit together the internal coherence of the project's components, how the project components, how the project's objectives and activities are kind of interlinked and knit together to solve a common problem. And the theory of change helps people outside of the program planning process comprehend how you think that doing activity A is going to get you to outcome B, or impact C. And so one of the things that we'll talk about next are the differences between things like inputs or activities, outputs, outcomes, and impact. So I'll walk you through those stages in the log frame. But that log frame rests fundamentally on the theory of change. So the purpose of the theory of change or the development of the logic model is to identify major problems and their main causal relationships, as you may have surmised. And so basically, you as a project planner or your team is challenged in this step to simply and coherently state, what is your idea about why your project will cause a change? And it's not a theory unto itself, like there is no universal theory of change that I'm referencing here. It's your theory of change. What do you as the planner believe is the relationship between your activities and your proposed outcomes? And so one time I was working my way through a theory of change workshop with some colleagues in Uganda, and my main counterpart on the ground there, when I first opened the topic, just kind of groaned and rolled his eyes, and he's like, another theory. And he didn't want to hear any more theory. He really just wanted to come down to brass tacks and talk about how they were going to get the work done. And so it was important to explain to him and the rest of the audience that there is no theory here. The theory is your theory, and that's what's important. So the output, like I was saying before, is what we call a problem tree, and that has cause and effect illustrated on it. So here's a very simple problem tree to illustrate this idea. From the bottom to the top, you go from cause to effect. And it can be, you know, sometimes depending on the problem that you're solving, it can be really complex. And this one I just really sort of vastly oversimplified the testing challenge and its relationship to COVID-19. So the cause is we have insufficient testing for the population size on the one hand. On the other hand, we have a population where people don't know sometimes that they're infectious with the virus. That leads to our fellow citizens unwittingly infecting one another. And that leads to the effect that concerns us all, which is that Montanans are falling ill with COVID-19. Another way of showing a logic model other than a problem tree is just kind of linking together inputs to activities to outputs with a series of text boxes that are linked with arrows or thought bubbles and the like. And so this is a logic model that I developed for a grant that I was working on recently, where we were proposing that funds would be provided for behavioral health activities. And those are described in the 4 bullets in the top left box. Those activities would lead to a statewide centralized public health network that was focused on behavioral and mental health outcomes, and also for individuals obtaining mental and behavioral health support of various kinds. Meanwhile, alongside the development of that health network and the provision of mental health care, training would be happening in the community about the social determinants of behavioral and mental health outcomes. That would be occurring in schools and communities across the state. And at the same time, bottom left, discussions are developing with health policy decision makers in rural and tribal populations and locations. And this would enable the thing in the thought bubble, which is that community-wide changes in attitudes and behaviors toward and about mental health would change, and increasing awareness of the integrated behavioral health approach. What is that, and why should anybody care about it or engage in it, community level? And ultimately, that would lead to decreasing social stigma about mental health and mental health care, and increasing awareness of the importance of an integrated behavioral health approach to addressing mental health, which would ultimately lead to improvements in mental and behavioral health and decreased healthcare costs overall for Montanans and their insurers. So that's another way of kind of thinking about graphically illustrating a logic model or the kind of connection in your mind as a project planner between parts. The log frame matrix, which I taught you about before, is, however, something that you're going to want to include whether or not you have a problem tree or a graphic like the previous one in your project plan that you present to your funder or your supervisor. You're definitely going to want to have the log frame matrix. So that's that 4x4 16 cell matrix I showed you before, and this one's populated related to COVID-19 testing. So you can see here on the left, again, we have the narrative summary. It starts with inputs, which are things that, you know, as the label would have you believe, there are things that you input into the project effort. That leads to certain kinds of outputs, which bring us to achieving the project's purpose and ultimately to reaching the project goal. Sometimes the goal is also referred to as the impact. So in this case, the inputs, again, a very oversimplified model of a program, but to get us thinking, the inputs are test kits, labor, and travel. Outputs would be test run. The project purpose is to improve knowledge, our knowledge in the public health and health care communities of the spread of the virus. And then the ultimate goal is to improve coverage of COVID-19 testing. The objectively verifiable indicators follow next, and you can see they're very, very simple. Like I said at the beginning, at the outset of program planning, I think it's really smart to start with relatively simple indicators that are pretty easily measured and see what you can do just with those. Before you overly complicate anything, start simple. In this case, we are going to start with sites across all Montana counties, and we're going to roll out 1.05 million coronavirus tests, and that will lead to outputs, which are test results. It will meet the project purpose by helping us understand the per capita incidence of disease, and ultimately we'll know from the number of tests run, we will increase the number of tests run from our current phase, which is relatively limited tests being run, to the goal, which is universal coverage in this hypothesized project. I'm not saying that that is actually a goal in Montana at this time. In terms of means of verification, basically in this column in your project plan, you're going to want to talk about what are your data sources. So where are you going to get the information that is going to be used to fill in these indicators. And then last are your critical assumptions. So to begin with, you can't do any testing if people don't come. So that's an assumption that people are going to come. You can't get test results that you can rely upon if the tests aren't accurate. So that's an assumption. The tests are going to be accurate. You can't figure out the per capita incidence if you don't know your population. So you have to have accurate data on your population. And last but not least, you can't improve coverage for COVID-19 testing if the state through DPHHS or other places doesn't have enough funding. Like I said before, all of these log frame matrices are built on these sort of very simple and logical series of if-then statements. So if your test kits and your labor and your travel are input, and people actually come to the testing that you afford them or make available to them, then you'll get your tests run. If you run your tests and the tests are accurate, then we'll improve our knowledge of the spread of the virus, etc. So you can see how those things all sort of fit together. That brings us to our objectives. Step 8, and delineation of what are the precise objectives of our project. Okay, for starters, we go from our our problem tree to the output of this step, which is the objective analysis. So this transforms the problem tree into an objectives analysis or objectives tree. It restates the problems as objectives. So the problem statements are converted into positive statements. like for instance, say you start with no one knows what public health is, that becomes, we will educate our partners about public health by doing XYZ. That's an example of changing from a problem statement to an objective statement that's positive and it's framing. The top of the tree is the end that is desired, and the lower levels are the means to achieving the ends that come at the top of the tree. I love at this stage of teaching people about planning and evaluation to introduce the concept of SMART objectives. And SMART objectives are ones that follow this, acronym. So SMART stands for, I guess, S stands for specific, M stands for measurable, A is for achievable, R is for relevant, and T is for time bound, sort of picking up on a lot of the principles that I've already explained in previous slides today. And so when you're thinking through the choice that you make of what your program's objectives are going to be, it's always good to have this kind of SMART acronym in mind and remember what those letters stand for. And I'll return to that in a few minutes. But when we're thinking about the objectives tree for the COVID-19 testing problem that we're sort of working our way through, we just restate it. We make education about the virus available. We make testing centers available to people. We make affordable testing available to people. These are some of the means that you might imagine, leading eventually to infected individuals being identified, initiation of contact tracing by those infected individuals, and then with the ultimate goal of containing the transmission of the virus. And so the objectives tree just kind of flips conceptually the problem tree into a series of positive statements of things that can be done. So the objective tree, you know, these trees or these schematics don't always appear in a program plan, but they're really important sort of heuristics to use on your team as you're kind of thinking your way through what are the connections between our program components, how is one related to the other, making sure everybody understands from the inside out why you've chosen each program component and how you're going to measure it, success, and so forth. Okay, measuring success is the next topic, and that brings me to the whole field of evaluation. And I wanted to start out before we get into specific types of evaluations by speaking briefly about evaluation history and context. I think it's really interesting, and I realize some people in here are even looking at a career change, and maybe Haley was talking about going into global health, and thought it would be interesting to folks in this group to know that evaluation is the #1 sector in global health that's currently hiring. So knowing about evaluation and how to do it and where it comes from is actually quite important in this day and age. So this is really social science research methods investigating the effectiveness of development aid or other social program aid. So evaluation is by no means specific to public health. Started in the 30s, actually, in this Western Electric company's plant. And what we've seen since the 1930s is that the call for program evaluation has kind of waxed and waned over the decades, depending in part upon politics and how much scrutiny program execution is receiving from legislators and their constituents. So in the 30s, initially, evaluation emerged in the context of a business and sort of helping that business understand whether or it was being as productive as it could be, and if not, why. And the evaluation industry has come a long way since then, and now spans over virtually every sector that you could imagine. And the interesting thing is, again, about the portability is that the toolkit is the same. It doesn't matter if you're evaluating how productive teams in an electric company are working together or how productively they're working together, or if you're talking about public health program, the bare bones of the way that you do evaluation is the same. It's a very portable toolkit. Assessment usually occurs across 5 domains: need, design, execution of project elements and service delivery, impact, and efficiency. The challenges are quite substantial in evaluation, and that can be affected by the whether or not the evaluation team is internal to an organization or whether it's external to an organization. I'll talk about that a little bit more in a few minutes. So as I said before, if your project or program that you've planned or are trying to evaluate occurs across a number of years, circumstances can change, and programmatic change has to follow. Oftentimes there's a tension between what are, maybe could be grouped as scientific or research design considerations and pragmatic considerations. So the gold standard for evaluation is the randomized controlled trial. And in many cases that's not feasible because, or RCT, it's not feasible or ethical. They're very expensive, generally speaking, compared to other kinds of evaluations. But they still are held out as the gold standard. And at this point in time, particularly in the global health arena, but domestically as well, the evaluations that tend to get published and the most attention, in my experience, do tend to be RCTs. But most organizations can't really invest as much money into the evaluation arm as would be required to run a proper RCT. So we always have the budgetary constraints. We also have the importance of asking the right questions. And I would say that all evaluations have to be crystal clear on the difference between your outputs and your outcomes. And how to frame questions to get at these two very different things within time, ethical, and budgetary constraints can be tough. But I'm hoping as a result of this training that the difference between an output and an outcome will be very clear in how to choose metrics that are relatively inexpensive and relatively easy to measure and collect data on will be clear to you guys. So I wanted to talk very briefly about bed nets and malaria reduction as an example of a difference between an output and an outcome. So in the pictures in the bottom left of your screen, you can see 2 uses of anti-malarial bed nets that were not intended by the program planners. So I see there are some questions in the chat box. I'll just click over here. Oh, we're going to break soon, so don't worry, Emily. If this program's evaluator were only to measure its efficacy based on outputs, this anti-malaria bed net distribution program succeeded in that it distributed lots and lots of bed nets to the population in question. But in terms of outcomes, in this case, those bed nets did not achieve their desired end, which was to reduce the incidence of malaria because people weren't using them for that purpose. In the end, they were more likely to use their bed nets for fishing or for bridal veils. And so the project planners did not anticipate that outcome, and the evaluators, had they not made sure to follow up on how usage patterns looked on the ground, they would have totally missed that. And so it is really important to distinguish between outputs and outcomes for that very reason. So I think I'm going to pause there and allow everybody to take a bathroom break. We're up to 11, so we've got an hour left. So I'm going to stop for, I think Emily suggested a 5-minute break to use the bathroom, and then we'll continue. Emily, can you hear me? All set, everybody? Can you hear me? Okay, good. All right, so I hope everybody's back. So we'll continue. Okay, a little bit more about history and context. So this funny cartoon on the top right, at least I think it's funny, shows people choosing the path that's, very few people choosing the path that says complex but right, and lots of people choosing the path that's simple but wrong, and then they fall over a cliff. So the point being that metrics that are simple and easy are usually inadequate for some kinds of programs. And so I advocate for starting with simple metrics, but what we find is that programs that are oversimplified, especially multi-pronged programs, like in my case, I've worked extensively on diarrheal disease. If you have a very simple metric, like how many latrines were built, it can oversimplify the problem, which is that diarrheal disease isn't simply the lack of toileting facility, but it's also to do with many, many other factors that come together in terms of the various vectors for diarrheal disease and the behavioral components to the way that people are interacting with unclean water or human waste, etc. And so if you grossly oversimplify a problem, then it can lead you to metrics that are oversimplified to a point that you won't capture what your project is really aimed at capturing. So that might sound like saying a different thing from before, like where I was advocating for picking metrics that are not over, you're not overthinking them. It's the flip side of the same coin. You don't need a metric that's very, very difficult to measure and overly complicated in that way, but you need to choose the right metric for the problem that you're intending to resolve. We also see that we need to make sure that we're not choosing a metric that doesn't actually measure what we think we're changing, or that has oversimplified it to an unrealistic extent. And so, for instance, with the BedNet program before, if the measure had simply been the number of, the measure chosen to determine the efficacy of the program had simply been the number of bed nets distributed, then, and the program implementers noticed that malaria rates had decreased, they might imagine that it was because they had distributed X number of bed nets, when in fact something else happened that was co-synchronous with their BedNet program that was actually the thing that reduced rates of malaria. Like maybe there was a very, very dry year because of climate change or what have you, where the number of mosquitoes in the environment simply dropped because of exogenous environmental factors and nothing to do with the BedNet program. Or maybe somebody else's program that was happening in the same neighborhood at the same time that the program planners or program implementers didn't know about was actually having a very profound effect on the incidence of malaria, and again, had nothing to do with that program's distribution of bed nets. So I think that we really need to think very carefully about choosing our metrics and making sure that they are, on the one hand, not over complicated, on the other hand, appropriate to the program or the problem in question. So one of the reasons that there can be tension around monitoring and evaluation is because people on program teams that are being evaluated or being monitored feel like they're being audited. And an audit in the sense from the financial world, like your finances are being audited and maybe there's some suggestion that you've done something wrong. And I would argue that M&E should never be perceived in that way, or that perception should be stopped in its tracks if possible, because it's important that everybody feels like, all stakeholders feel like the monitoring and evaluation that's done on a project is to help everybody achieve their shared goals. It's not being undertaken as a way of catching somebody up or putting somebody into a bad spot, but it should only be perceived as a way of improving quality and giving the feedback necessary to make tweaks mid-cycle to improve outcomes at the end. That brings me to another problem, which is in-house versus external or outsourcing monitoring and evaluation. And I want to talk about that in a little more detail in a sec. And then last but not least is another consideration is the generation of data that nobody uses. And so in our monitoring and evaluation work, we want to make sure that I guess it goes back to not picking overly complex data points or metrics that are very time consuming or too many metrics that measure the same thing and generating a huge abundance of data that nobody ever actually uses, which unfortunately is the case in a lot of low resource settings that I've worked in around the world, where they're still using paper forms and none of those data are ever digitized, and so they become useless to anybody for making programs better. I would say that looking good and avoiding blame mindset kind of goes along with perceiving evaluation as an audit. And it's really sort of simple because people want to look good and they want to avoid being associated with failure. And that causes people to, if programs are not delivering, that causes people to resort to the subjective interpretation of reality way of thinking about their program and whether or not it's reaching its intended goals. So they might say, well, the evaluator had a weakness of some kind, or they might think, well, they might say the evaluator had imperfect information, and so that's why that happened. So it's really important, I think, to understand the evaluation literature on similar public health problems to the one that you're combating in your planning or program planning process, so that you can see how other people who are evaluating similar programs chose their metrics and how they sort of designed their evaluation process and how that worked for them. I also would advocate for the critical importance of data triangulation or using mixed methods whenever possible. So you might use quantitative methods on the one hand from databases that are available through the state or from data that you're collecting yourself, and then combine that with qualitative or attitudinal information that can really enrich the quantitative findings so that you can develop a nuanced and sophisticated understanding of what motivates the behavior in your clients that you're targeting with your program as possible. And all of this rests upon trust factors and the trust being established between the evaluators and the program implementers, as well as between the program implementers and the clients that they're hopefully benefiting. Can you guys read my cartoon over here on the right? This man speaking says, and now at this phase, at this point in the meeting, I'd like to shift the blame away from me and onto someone else. So trust factors, also important to recognize, can be partial or full. They can trigger both of the phenomena described above, et cetera. So I think that trust building through the stakeholder analysis and stakeholder engagement process is so key, and why I said at the beginning of my remarks today that a failure to engage and understand and build trust with stakeholders is, I say, one of the most common reasons where projects aren't achieving their intended aims. Okay, what we have to know in the evaluation world is that sometimes people don't want the evaluation to proceed. They maybe want to avoid scrutiny. They will use different kinds of tactics to avoid scrutiny. And as evaluators on our own programs, or maybe some of the folks in our group will move on to careers in evaluation, we have to always be aware that these things can be happening. Once evaluations have begun, what we can see is that people might, maybe not give you as good information as you really need to get the evaluation done well. And even at the interpretation stage, once you have finished your analyses and you're presenting your findings, you can run into the same kinds of problems and obfuscations. So, a lot of this some of these tactics that you can see on the screen here can be avoided if your evaluator is from within the organization, one would like to think, but not always. And I will talk more about external versus internal evaluators in just a moment. So where does M&E fit into the program management cycle? And so you can see here in my estimation, in this borrowed schematic, that monitoring and evaluation fits in every phase of the cycle. It has to be a part of problem identification and cause analysis right from the start, into goal and objective setting, in the execution of the implementation plan, and then in the service delivery right on through, and then back up to the start. So M&E is not something that should be left to be done at the final sort of exit stages. It should be something where your M&E team, if it's not you yourself, should be at the table at the time that you're planning out the program from the start. And M&E teams are often very sophisticated, or evaluators who've done this kind of thing before can have a lot of insights and inputs that can really help you concretize your goals and your objective setting, and then how you go through implementing a plan that can be appropriately evaluated. So I keep talking about monitoring and evaluation, and I just wanted to pause briefly and make sure that you guys understand the difference. So monitoring is more on the sort of on the output side, on the more of the fine-grained, like what project activities are being completed, what project outputs are being generated. And the evaluation is more panning out on the bigger picture side. Are the project purposes being met? Are the project goals or the impact being achieved, etc.? So there are two sort of, two phases of the same process. So, or two levels of the same process. So monitoring is a little more micro, evaluation is more macro. Both have to happen in concert. This slide I'm going to skip over and let you guys read at your leisure, but it just goes into a little bit more detail on the difference between M&E. Okay, I've mentioned before that we have our four sort of levels of project components that you're going to want to name and define very clearly in your project plan. That goes from the start with your inputs, next comes to your outputs, next are your outcomes, and last are your impacts. And there are sometimes different terms used for some of these. Sometimes outputs are also known as activities, outcomes can be known as purpose, impacts can be known as goals. And so that usage is, or kind of going back and forth in usage between those terms is quite common in the planning and evaluation sectors. So just a little bit more language here on the differences between inputs, outputs, outcomes, and impacts, and I'll let you read through that more at your leisure in the interest of time. So we'll share the slides with you later. So some of these details you can go through on your own if you're interested. Okay, so I've been referring to this trade-off between internal and external evaluation, and I think it's something that you're going to want to think through. So when you have an internal evaluator, or you yourself are evaluating your own program, there are some advantages and disadvantages. Some of them I've alluded to already in some of my previous slides, but others are described here. Advantages are you have insider knowledge of the organization, you can interpret the behavior of organizational members, you might have more access to important internal information or institutional memory that an external evaluator wouldn't have or be able to have access to. It's usually a cost-saving measure to have an internal evaluator. You don't have to recruit anybody or train anybody up or spend any time talking about the history of the organization. But the disadvantages are there as well. And they would be things like you might lack objectivity about your own program, or you might accept the position or agenda of or assumptions of your organization in ways that you've sort of internalized or become blind to. That might be things that an external evaluator would say, hey, have you ever thought about this before? I'd like to put this on your radar screen, etc. So we can lose the forest through the trees sometimes when we're internal to our organization and doing our own evaluation. You know, other things as well, like evaluators, if you're also the project planner and implementer, you're very busy. And maybe you don't have subject matter expertise on doing an evaluation or a research design or what have you, and an external evaluator hired just to do that would have all of those skills on board. So those are some of the considerations to bear in mind when you're thinking about external and internal evaluators. And if you are an internal evaluator on your own program, why you would maybe want to ward off or head off some of these potential liabilities or risks before they actually take effect. Okay, so before you start planning your evaluation, you need to think about some things. First of all, what's the purpose of your evaluation? And what kind of evaluation is it going to be? Is it going to be a baseline or evaluation done at the beginning? Will you be doing a midpoint or formative evaluation that takes place sort of mid-project cycle? Or will you be doing a summative evaluation? Ideally, any project which is being implemented will have all three types of evaluations occurring at different points in the life cycle of the project. But you know, each of them requires a slightly different mindset and set of emphases. Obviously, you're gonna have to decide who does the evaluation. Maybe it's just gonna be you. And then you have to go about reviewing existing information in program documents, including what kind of monitoring information is available. So what kind of information, what kind of data can be made available to you on how a project is ticking along. If you're doing a midpoint or a summative evaluation, you need to know like what bits and pieces actually got done before you can start panning out and talking about whether the purpose or goal was reached. You have to look at what are the available information sources. And then you're probably going to have to, if you're an external evaluator, you're going to have to get some help describing the program. And on the box on the right, you can see some of the descriptors that you would want to get some information on from people internal to the program. Then you have to choose your evaluation methods. So these are going to develop based upon what kind of evaluation it is. Like if you're doing a summative at the end of a whole 5-year program, it might be appropriate to use different kinds of methods than you would use at day one, doing a baseline evaluation. These help you, or choosing what your goals and objectives are for the evaluation itself, not the program's goals and objectives, but the evaluation's goals and objectives, will help you formulate your evaluation questions and help you decide the evaluation design, what your measurement standards are going to be, what your indicators or metrics are going to be, what schedule you're going to follow together with your evaluation team, and what budget is required. I like to walk people through what some potential sample evaluation questions would be, and I base those on what stakeholders would want to know. So going back to the importance of stakeholders, I think it's really critical to think about who's going to read my evaluation. And I would imagine that in every program, there are the first audience that I'm going to want to meet the need of is going to be the stakeholders themselves. In other words, you know, the folks from maybe the local health department or DPHHS or the clients themselves or the clinicians that I worked with, etc. And so I've broken up the questions here into the difference between questions that you might get from program clients, from program staff, from program managers, funding bodies, and the like. And so you can see some examples here of ways where you might think about differently evaluation questions that you would want to get answered depending upon who your audience is. Okay. Next slide prompts me to pause for questions. So I'm just gonna pop over here to the chat screen and see if anyone's posed anything. Okay, so Marilyn says, meaningful metrics tied to program evidence and not personal performance. Yes, a well-written plan and executed plan helps with program performance versus personnel performance. A good manager is key to differentiate the two, but address both. Yes, I'm so glad that you made that point, because program evaluation is not personnel management, is it? So personnel management is a key tool. I mean, my goodness, the number of skill sets each of you is bringing to the job is really amazing and considerable. And I'm always impressed by students or trainees in these classes and how many different hats you all are wearing. But Marilyn is absolutely right here. These are separate areas, but obviously they're linked together, because if you're distracted by a low performing staff member, then you can't manage the implementation of the program as effectively as you otherwise might, and you're distracted by those kinds of intricacies, or just sort of the daily challenges associated with a difficult personal problem. That's a good one. Any other questions before I move on? Okay. This brings us to indicators. Okay, what is it? An indicator is a standardized objective measure that allows, for instance, a comparison among health facilities, or maybe a comparison among countries. Maybe it's a comparison between different time periods that you're interested in. Generally speaking, it is a measure of the progress toward achieving program goals. Characteristics shared by good indicators are as follows. One is clarity. Another is that it's useful. It represents all the important dimensions of performance of that program component. It also needs to be measurable. It's very difficult to work with metrics that are impossible to measure in some fashion. Quantitative measures are probably very familiar and comfortable to a lot of people in this training. Those are things like rates or proportions or percentages, or thinking about what's the common denominator for your clientele, etc. So those are probably very familiar. More qualitative things about people and their beliefs or perceptions or attitudes can also be measured very simply with a yes or a no, or in a more complex fashion with a Likert scale. A Likert scale is when you're asked to answer like an attitudinal question by saying like, I strongly agree, graded down to I strongly disagree. That's a Likert scale, and those can be fairly easily quantified and turned into something that you can statistically analyze. So there are sort of some tools that we use to capture qualitative information in a way that can then kind of feed into the quantitative analyses, but that depends on how you ask the question. And so thinking forward to what is it that you want to do with the answer to the question that you're posing ultimately is important to know, because that helps you decide how you want to frame the question, if that makes sense. In other words, if you want to say, X% of the population agreed that vaccinating for HPV is extremely important, then you you need to know that somehow your question has to generate information that you can turn into a percentage. So if you ask the question in a sort of open-ended fashion that people can answer any which way, it can be difficult to turn that into a percentage. But if you ask it in the form of a Likert scale, then it can be fairly easy to turn it into a percentage type of a response. Good indicators also are reliable. So in other words, they can be collected consistently by different data collectors. And in other words, there's no confusion about what it is that the metric is or indicator is capturing and how to capture it. And then last is validity. In other words, the measure, it has to, or the metric has to measure what we mean to measure. There's a whole literature on validity and validating, for instance, scales or questions on a survey and so forth, which are beyond the scope of today's session, but these are the main characteristics of good indicators. So when you're thinking about choosing your indicators, you do need to have those in mind, and that's step 9 of our 10-step process. Okay, so as you may have surmised, indicators demonstrate to what extent our results have been achieved, and they specify the achievement, or sorry, they specify how the achievement of an objective can be both verified and understood. They are the very foundation of a project's monitoring and evaluation. If you don't have indicators, then you can't do any monitoring or evaluation. Here I have reminded you of the 4x4 matrix that I showed you before on COVID-19 testing. And what I want to emphasize to you here is that I've chosen a set of metrics or indicators for this, relatively oversimplified approach to rolling out a testing problem or program. But you can see that the metrics that I chose are all, very defined. They're relatively easy to capture, and they are they measure what I want them to measure. They are things like how many tests were performed, how many of those tests were positive versus negative, based on the population size, what is the per capita incidence of disease. These are measuring exactly what I want them to measure, and they are relatively easy to collect if the inputs and outputs flow nicely one into the other. In other words, if none of those assumptions are violated. So in that way, you can see how, as long as you're choosing the right metric, it can be a pretty simple metric and not something that you have to complicate. This brings us back to those SMART metrics that or SMART objectives that I mentioned before, that SMART objectives lead right into SMART metrics. So SMART metrics are those that are specific. They relate directly to the processes that you're trying to influence. They're measurable. They derive from actual numbers. They're accurate in that they are and can be and are precise and consistent. They're reliable. They can be clearly defined and understood by all data collectors or measurers. And they're timely. In other words, they don't get better with age. They're just as good today as they will be tomorrow if they're collected accurately. And that brings us to step 10. Step 10 is check your assumptions. And I know we've had a couple of questions on assumptions and helping you understand what is a killer assumption, and that's in this section. Okay, so what are these assumptions and why are they important? Well, for starters, they describe the necessary internal and external conditions in order to ensure that the activities that you're proposing or that you're planning are going to produce the results that you want. They are risks. Every time you assume something, you're taking a little bit of a risk that your assumption is wrong. and as such, they can jeopardize the success of a project, but we all proceed making assumptions every single day in every single thing that we do. So assumptions aren't, I don't want to overblow it. They're just part of, existing. But in project planning, I think it's important to be quite concrete, or as concrete as possible, about what assumptions you're making, and have a game plan if those aren't going to continue to pertain. So generally speaking, in program planning, what we see is that assumptions are worded positively. In other words, they describe circumstances required to achieve certain objectives. And they should be obviously relevant and also probable. And if it's not important, just don't, if important or almost certain, just don't include it. If an assumption is unlikely to occur, then it's a killer assumption and you should abandon the project. So a killer assumption with COVID-19 would be that, like, for instance, if we were to together write a program plan and pitch it for funding, and one of our assumptions is that people will only come if it's not raining out, and that it's never going to rain. It's kind of silly, but it would be an example of a killer assumption. Like, you can't plan your project contingent upon something that there's a very high likelihood that it won't obtain. Maybe we might say, we're going to plan that all 1.05 or 1.09, depending on what estimate you're looking at, Montanans are going to make themselves available for the test. And the project is going to fail if every single one of them does not do so. That's a killer assumption. It's not actually an assumption of the simplified plan that I proposed, but if it were, if your plan were contingent upon having 100% participation or even close to 100% participation, that's not a good assumption. And generally speaking, people who are as experienced and knowledgeable and practical as folks in this group are not going to be making killer assumptions, because you're going to be rejecting them out of hand. It's only mentioned in project planning because sometimes maybe more junior or more or less experienced folks might run a plan by a funder, which does actually have a bunch of problematic assumptions in it, and we just don't want to see that happen from any of our trainees. So we would just assume that you would be thinking through these things quite carefully before running something by a potential funder. Okay, some examples of assumptions that we're seeing people make across public health program planning are assumptions about, like, political factors remaining stable or in place. So the stability of government support for strategy and availability of government staff, that's a reasonable assumption, usually, in the United States. It is not reasonable in lots of low resource settings where I've worked in other countries. And so a relatively naive or more junior project planner or program planner coming into, say, a Nepalese setting who is going to pitch a plan that was contingent upon government stability that would not be funded, because that would be a killer assumption. In the time that I've worked in Nepal, even over a couple of decades, I would say there have been probably 25 changes of government, and each time there's a change like that, it introduces some instability into all sorts of things, including availability of staff. Another assumption would be a sustainable economy. Generally speaking, we can make that assumption in some settings that we work in other settings not so much. Maybe we would assume adequate funds, materials, that sort of thing. That's a good assumption, hopefully, if you're thinking things through. We would assume skilled people and their training needs would be met. We would assume also that approvals and contracts were going to fall into place. Maybe those legal and administrative matters, though, weren't thought through completely by program planners, and there you have a killer assumption. Sometimes we see program planning falling down at the point where we're looking at an ethical review of the participation of human subjects. That's an example of a killer assumption for, you know, folks who haven't been through the planning process a number of times and sort of learned that the hard way. Participation of stakeholders, that's also an assumption. And sometimes that is the Achilles heel. That's the place where you've built the project based upon, built the project plan based upon having a group of keen and enthusiastic stakeholders, but then those stakeholders are, and maybe they might be voted out of office, or they lose their job, or they lose their funding, or for some other reason they lose their enthusiasm. So that can also come into play. Okay, so that is the final step, step number 10 on examining your assumptions and looking out for those killer assumptions. So that brings us to the very end of our time together working the 10 steps. Now, what I have assembled for you next, I wasn't sure if I would get to, I didn't know if I would have time or not, but are just some considerations that don't really pertain directly to program planning or program evaluation per se, but will walk you through some other considerations that I personally think are important and worthy of consideration, or, you know, just some time having a think about each of them. So because we're closing in on the final 15 minutes and I wanted to leave time for any questions that might have arisen, I think I'm just going to flick through these like fairly rapidly, and I'll just mention the title and maybe say a piece, a very short thing about each one. Okay, so the first thing I wanted to talk you through was when you're implementing your program, what are some considerations that pertain, no matter what the program is, what it's focused upon, what its particular area is or population. I also continued this by thinking through some issues having to do with personnel management, like we were just discussing with Marilyn's question. What about program implementation in terms of resources and stability, or other things that might be unique to particular geographies or particular cultural areas? Something that program planners, I think, spend an inadequate amount of time on is thinking through what their exit plan is going to be. So once the funding dries up, if a renewal isn't available, or the program has to phase down, what will that phase down process look like? And there's a whole literature on exiting programs, on phase over, phase down, phase out, different modalities of approaching the end of a program implementation phase, and how to do that well. That would be subject of a whole other seminar probably, but which I wanted to at least acknowledge here in talking about resources and sustainability. Last but not least, I wanted to talk about producing and sharing information and some things to think about if you're thinking all the way through the project planning cycle, past the evaluation and into the part where you're disseminating information. So I have drawn up some slides on producing and sharing information, drawing conclusions, how you describe your results depending upon the kind of evaluation that you might do. And then last but not least, some things to think about visually displaying information in graphs and tables and so forth. Okay, last, how are you going to write your conclusion section to your evaluation, and how those conclusion sections might differ if project goals were or were not met. Last is dissemination and how to address additional concerns or questions that might arise, especially if project outcomes were not met. And finally, I wanted to encourage you to think all the way through, not just to writing that final report or disseminating information, but really broadly disseminating information, and encourage you to think about where you might want to take things in the end. I mean, maybe you would want to author a paper, maybe you would want to present some findings at MPHA at our annual conference. The annual conference this year is in Missoula, September 22nd and 23rd, and the proposals for that are due on May 31st. So if we're all forward thinking and imagining that our days suffering from our stay-at-home order are limited and are going to come to an end, we're all probably going to be really looking forward to gathering for MPHA and talking about all of the good work we've been doing, how we've evaluated it, and what our evaluations showed. So I can see here that there are a couple of questions that are in the chat box. So let's see. Oh, Marilyn talked about exit. And no other questions per se, but some thank yous and reminders that a bunch of folks have to jump off for a call at noon. So let me switch back over so I can see everybody's faces. And I guess just end there with a thank you and a goodbye, and make sure I've answered the questions that might remain before you jump on to your next thing.